Namaskar dosto and good evening friends. Welcome to 4D season 3.0 and this is episode 6 of 4D. 4D means detailed discussion and dialogue in diabetes, in Indian diabetes, and that's what we are here for. Some people will say, why season 3.0 and how long do you need to keep on discussing and having dialogue in diabetes, that too in a detailed manner? And the answer to that is very simple. As long as diabetes is there, as long as metabolic syndrome is there, and as long as the complications of this disease are there, we need to continue having discussion and dialogue. If diabetes is a dynamic disease, multifaceted, multifactorial syndrome, then we need to be more dynamic than that. And if we need to do that, then we need the most dynamic hands on board. So let's welcome our experts for today. And these experts hail from the pink city of India, Jaipur. So let's welcome them one by one. A warm welcome to Dr. Aneja, Dr. Ankita Aneja. Warm welcome, madam.
Thank you so much, sir.
Dr. Aneja is an endocrinologist trained at the prestigious Safdarjung Hospital in New Delhi, and now she works in Jaipur. Warm welcome, ma'am.
Thank you so much, sir. It's a pleasure being here.
The pleasure is ours and people from across India listening to you. We'd also like to welcome another equally dynamic colleague, Dr. Ashwini Sharma, an invasive cardiologist trained at PGI Chandigarh and now working in Jaipur. Warm welcome, Dr. Ashwini.
Thank you. Thank you.
Dr. Ashwini, there's a question for you from the audience, and this comes from Dr. Kamal Kishore in Karnal. He says, the pink city, the heart is pink. What would your statement, what would your opinion be about this statement? Is the heart a pink organ?
Actually, I'm not fully agree with this statement. It's you can say that it's a pink because of blood supply. Otherwise, it's a muscular organ. It's not pink.
So multiple shades of the heart as well. We'll discuss that as well. And so sometimes you can have a black-hearted person, somebody who's very upset, angry with life. And then otherwise you have large-hearted people. Again, in English, large-hearted would mean something. But for the cardiologist who's doing an echo, large-hearted may mean something not so pleasant.
Yeah,
We'd also like to,
for us.
yeah. We'd also like to welcome another colleague, Dr. Lavdeep Dogra. Warm welcome, Dr. Dogra.
Hello, sir. Good evening. Well, good evening, everyone.
Warm welcome. Dr. Lavdeep is trained at Osmania Medical College in Hyderabad, and now again he offers his services to the citizens of Jaipur and Rajasthan. So our topic for today is metabolic syndrome and how this links all of us together. Dr. Ankita, most of us do understand Hindi, and it is said that metabolic syndrome ke dhol baj rahe hain in the country. Dhol is a word used for drums. So the drums are beating loud and strong. Do you feel that is correct? In the sense from an epidemiological perspective. Yeah.
Bilkul, sir. I think you are absolutely right with the epidemic of obesity, with the epidemic of diabetes, and we are leading in every wrong way. We are leaving China behind when it comes to diabetes. There's an epidemic, there's fast life, there's fast food, which I feel is there's a lot of stress, which are the main reasons for this epidemic of obesity and metabolic syndrome, sir.
So, thank you, ma'am. Like you said, metabolic syndrome is common. It's become part and parcel of our lives, actually. And you identified some of the causes as well for it. Dr. Ashwini, does this metabolic syndrome extend to the cardiology OPD as well? So, specific question about OPD practice, not about indoor. Do you feel that most of your patients have metabolic syndrome?
Yeah, it's true, sir. So the people are suffering with one or a more component of the metabolic syndrome now, and these people, and these are not the classical adult people. We see the adolescent persons also suffering from these components. No doubt, it is true that the metabolic syndrome is not CP, it's not creepy. Rather, we have to face the battle with metabolic syndrome.
And Dr. Dogra, in nephrology, now when I was a student, our nephrology ward and OPD used to be full of very frail, thin, skinny people. Now I'm told that's not true anymore. Do you see metabolic syndrome, well-built people in nephrology, in the clinic, in the OPD practice?
So true, sir. Actually, we practice as kidney physicians, basically. We're working on almost all aspects of metabolic syndrome, patients presenting early in their disease, because as you rightly said, awareness regarding nephrology has improved over the past couple of decades, I believe. People present to us early, and when they present to us early, they are normal appearing. and not as frail as they would gradually become in due course of time if they ignore this problem. Now, taking this forward into metabolic syndrome, I also agree that all components of metabolic syndrome, to different degrees and different virtues by their own cells, contribute to development of chronic kidney disease and all other diseases per se. So nothing is spared from this. And eventuality, we are an eventuality, not the causality is at least, but we are at least an eventuality. This will happen, and this will lead to target organ damage, heart, kidneys, and the brain. So this is common, and we should be aware of this, and very wisely we should watch for all these symptoms as and when they come.
So metabolic syndrome is common in the country. Metabolic syndrome pervades all our practices, whether we are in medicine, in cardiology, nephrology, or in endocrinology. And that is true for all specialties, actually. It's not only the medical specialties like neurology or rheumatology which suffer the brunt. Even when you go to pediatrics or you go to obstetrics and gynecology, you find that metabolic syndrome is influence their attitude towards care, the kind of care that we offer. But Dr. Ankita, ये metabolic syndrome होता क्या है? What is metabolic syndrome? And the word dhol, how can we use that as a mnemonic to help us remember the various components of this syndrome?
Yes, sir. So actually, metabolic syndrome, I would say it's a constellation of metabolic abnormalities. एक group है जिसमें बहुत सारी lot of metabolic complications have come together. Like first is the diabetes, then second is the lipid disorder, third is the hypertension, then is the waist circumference. Then in lipid we take the triglycerides, we take the HDL. Dhol is something I would relate as ki patient looks like a dhol. Probably where we talk of the abdominal obesity, where we talk of the visceral obesity, which is very, very harmful. So it is not only one, but it is lot of multiple metabolic problems coming together is termed as metabolic syndrome.
And Dr. Archini, from a cardiac perspective, does the heart in metabolic syndrome, does that also end up looking like a dhol or like a drum?
It's not always necessary, sir. But say if the patient suffers from the heart failure, in heart failure with reduced ejection fraction, yes, the heart will enlarge. And obviously, if you do the echo, you see the chest X-ray, you will feel that heart is really enlarged, it's just like dhol, obviously, and most of the part of the chest is covered by heart. So yes, in certain manifestations of metabolic syndrome, the heart will be big.
Is it true that when you do an echo, now you can see fat in the heart? When we talk of ectopic adipose tissue, in general, in endocrinology or in medicine, we just talk about visceral fat and subcutaneous fat. Can you have pericardiac, paracardiac fat also? Are you able to see that on the machine?
Yeah, we can see the pericardial fat. It appears like it appears like as black as fluid. So at first impression, we might think that there is a pericardial effusion, but then it's not all around, and soon we can recover and make sure that it is the epicardial fat rather than the pericardial effusion, and it's really an indicator of visceral adiposity.
It's a nice way to share with our patients as well, with the public, because it becomes a very strong motivating factor. So when you tell someone that there is a layer of fat around your heart, it's preventing your heart from working properly, that actually serves as a wake-up call. Dr. Lavdeep, Dr. Lavdeep, the word dhol can be used to explain the picture, the phenotype of the person with metabolic syndrome. It can also be used to list the main components: D for dysglycemia, H for high blood pressure, O for obesity and overweight, and L, if you are speaking in Hindi, it would be liver. If you speak in Punjabi, then you get a double L, dhol. So the next L will be liver as well. But another term for drum or for drum is a dholki. So that adds the word Ki at the end, and Ki is for kidney. So what are the aspects of kidney function which you see in metabolic syndrome? Because it won't be complete if you don't talk about the dholki.
So true, sir. Actually, the kidneys manifest various aspects of metabolic syndrome in their own way. That not just in the form of atherosclerotic renovascular disease, the most common cause of kidney failure in patients with atherosclerosis, which eventually develops, but also secondary to complications not limited to hypertension, dyslipidemia, wherein we also get patients presenting to us with AKI due to secondary hypertension or with accelerated hypertension. Also, very commonly we get patients suffering from cardiorenal syndromes, wherein one part of the body affects the other part. So we have various manifestations when people present to us, both to the cardiologist as well as the nephrologist simultaneously, wherein managing metabolic syndrome would have been a wiser choice than managing these complications in the hospital. And as you said, as the physician rightly would say, practicing medicine in an OPD phase on an OPD basis is far more happier thing to do than doing it in an ICU, because that is when we realize how important small things are if they are ignored at a very early stage.
And these are some things where all of us, if let us say we tell our patients to get a urine albumin creatinine ratio done, or we look for microalbuminuria right at the beginning, we can screen, we can diagnose, we can treat early. And actually, in the older definitions of metabolic syndrome, microalbuminuria was given the same weightage that maybe high triglycerides or low HDL was.
Yes, even today.
Even today. Dr. Ankita, Dr. Lavdeep has now brought in this concept of crosstalk. He said cardiorenal syndrome. So the heart talks to the kidney and the kidney talks to the heart. Sometimes one organ leads the other in damage. At other times, they work hand in hand simultaneously and they move towards ill health simultaneously. But this kind of crosstalk, now all of us physicians gathered here, what I am aware of from physiology is that it is the endocrine system and the nervous system which ensure that all the organs of the body talk to each other, listen to each other. So let's focus on the endocrine system. And then we'll ask Dr. Ashwini to talk about the cardiac autonomic system. And then Dr. Lavdeep gets the toughest question. Dr. Lavdeep, there's a question for you from the audience. And you can answer after 5 minutes once your turn comes. But this question comes from the Ravya Sharma and Raghav Sharma. Both of them live in South Delhi. And they say, sir, what is the meaning of the English word pogonotomy?
Is that so, sir? Is that so? I would love to look up then. I would love to look up.
So we have 5 minutes. So pogonotomy. What's the meaning of this word? Like osteotomy. But Dr. Ankita, let's talk about the endocrine system. Endocrine system is made up of hormones. So which are the hormones which get this crosstalk started? The pancreas, the adipose tissue, the heart, the kidney, whatever comes to your mind, madam.
Yes. So hormones are basically the messengers which connect different organs. So today when we're talking of metabolic syndrome, the central or the epicenter, I would say, is the insulin from the pancreas. It is the insulin resistance, which then has a connection with all the organs. Whether it's going to be the liver, it is going to be the heart, it is going to be the kidney, it is going to be the gut, where gut microbiota is there. So insulin plays the central role. While we know that adipose tissue is hormonally a very active tissue. So there are various hormones like leptins, adiponectins. Then there are various cytokines like interleukins, TNF-alpha. So metabolic syndrome is a kind of an inflammatory state. All organs are affected. So once you have rise in these inflammatory markers or these hormones, ultimately it is going to involve every organ of the body, whether it is going to be your liver pancreas crosstalk, liver brain crosstalk, or the adipose tissue itself affecting all the organs like the liver, pancreas, kidneys, your gut, your brain, your joints, your bones.
So, ma'am, that point is very well explained by you. Like you said, all these hormones talk to each other. And the center of metabolic syndrome would be insulin resistance. We should also understand that in traditional endocrinology, we've always been used to a very Newtonian kind of a thought process. One thing leads to another. For example, T3, T4 go low, TSH becomes high. In cardiology also, a very Newtonian kind of a thought process. Earlier, BP is less, you give dopamine, dobutamine. BP is more, you give a diuretic. So a very linear kind of a thought process. And nephrology, of course, was never so well developed until the past 20, 30 years ago. There, the linear process was today you just control your BP with maybe with arkamine, and tomorrow you go for dialysis. But things have changed now. Now let's look at it philosophically. First of all, in physics, Newtonian physics now has given way to quantum physics or quantum mechanics. Einstein's physics, which says that energy and mass can come in various permutations, combinations. So similarly in endocrinology, all these various hormones talk to each other in a quantum manner. It's not binary, it is not linear anymore. You can call it a cobweb of causation, you can call it quantum physics, but you have to hear everyone. It's more like a democratic kind of a thought process, or a democratic talking and listening. So the same way we have of a democracy in India, all said and done, it does work. Similarly, the endocrine system does manage. But in case you have too much of power in one center, that's hyperinsulinemia, then things begin to get a bit shaky. So that's what happening. That's what's happening. So this is one way of looking at it philosophically. Dr. Ashwini, let's continue this further. Now let's look at it from a cardiac point of view. Let's give us two ways of thinking. The first is the heart is an endocrine organ. Of course, everybody knows the heart is an endocrine organ. It produces ANP, BNP. It produces growth differentiation factor 15. It produces myostatin. And all the physicians and endocrinologists of India are so busy that we are not able to take care of these hormones. So we thank you for taking care of it in the ICU. So that's one way. Another way of looking at the heart is that it is a target of hormones. So like Dr. Ankita said, whenever these hormones, whether insulin or growth hormone or cortisol, when they go out into the bloodstream, they are not limiting their action just to the blood. They are attacking the atria and the ventricles. They are attacking the conduction system of the heart. So with this now, what thoughts come to your mind, Dr. Ashwini? You've been in practice for a decade plus. Is cardiology changing from Newtonian cardiology to Einsteinian cardiology to quantum cardiology? What thoughts come to your mind? What challenges? What strengths?
Definitely, such things are rapidly changing, and Dr. Ankita has very well explained that that how the hormones connect one part to another part. Previously, we used to simply say that in a short term, in seconds or minutes, if organs are communicating with one another, then it is the sympathetic and parasympathetic nervous system. That means autonomic nervous system. And if the organs are communicating with either on hours or days or weeks or months basis, then it's the primarily the endocrine system of the body. But now we know that hormones works instantaneously as well as over long period of time. The same is true for the heart also. The heart communicates with the whole body, including kidney, including brain, including every organ on short-term basis, medium-term basis, long-term basis. So no doubt it is definitely there. Previously, we used to simply say, as you said, the linear method that heart by means of hemodynamics, by means of heart rate and blood pressure, it affects the kidney, brain, liver, etc. But now we know that it's not the simply hemodynamics only. Apart from the vital parameters, we know that it is the home for the inflammation. I won't say that it is a home for inflammation, but it is the one and target organ where inflammation has its effect. As we right now said that it is in case of central adiposity. If epicardial fat is there, it means that adiposity is putting effect upon the heart. So whatsoever parameters of the metabolic syndrome are there, if that is there in body, then that will definitely affect the heart, that will affect the other body organs also. So now, previously we used to say that atherosclerotic heart disease, atherosclerotic cardiovascular disease. Now we have changed from heart to cardiovascular. We know that every blood vessel have the impact once the atherosclerosis is there. Might be the kidney, might be the brain, might be the GI, might be the limb, or might be the kidney. Now, and there is addition of heart flow similarly, and then there is the addition of arrhythmia. There is an addition of inflammation. So we have multiple kind of risk: atherosclerotic risk, inflammatory risk, arrhythmogenic risk, adiposity-related risk. So definitely, it is a complex interplay of various factors, one affecting another in various possible ways. That's why the metabolic syndrome has now come into the core, where actually we are not enumerating four things. We are enumerating a process which can have any dimension and it can affect any organ and by n number of ways. That's why to pick up the metabolic syndrome in the current scenario is really a very good approach to take care of these disorders where there is metabolic syndrome within center.
Thank you so much, Dr. Sharma. To our thought process, now you have added one more gland, one more organ system, which is the endothelium. That endothelium is perhaps the largest endocrine organ in the body because it is so huge. And you have added one more pathology, etiopathology, to our thought process, which is inflammation. So it's not just about the autonomic nervous system, which gives you immediate conversation or immediate talk, or about the endocrine system, which is slightly slower than the autonomic nervous system. It's also about inflammation. So if you don't have inflammation, that's also wrong. It's a protective factor. It protects against disease. But if you have too much of inflammation, that also can harm the body. So thanks for raising these points. Dr. Lavdeep is with us as well. Dr. Lavdeep, Professor Manisha Sai from Hyderabad, she raises a point and she says that the kidneys are also endocrine organs, both the left and the right. Yeah. So which hormones come out of the kidney and how do they impact metabolic health? How do they impact cardiac health?
Actually, sir, kidney is actually an endocrine organ in a way that it not just does the secretion, the filtration part of the blood, it also releases a number of hormones which are not just limited to erythropoietin to increase our blood levels, then producing vitamin D, which helps in improving our bone health. It also acts as a sink, which helps us remove in various ways. It helps in removing the antigen antibody complexes which are made by the body, and thereby any damage or any injury, the kidney is going to bear the brunt of it. Whatever we are suffering from, be it hypertension, be it any other disease, or be it say for example, any of the substances which are being consumed by the Gen Z population these days so often that even that they are not into metabolic syndrome, they would develop very soon into this metabolic syndrome. All these things which we are consuming, be it on purpose or be it unknowingly, whatever we do is going to, the kidneys are going to bear the brunt of that. So having said that, yes, kidneys, Madam has very rightly said, kidneys are a metabolic organ. And being kidney physicians, we look into the parts of, we do understand that yes, because kidneys metabolize insulin, so our patients have a different need and different dose requirements for oral hypoglycemic agents. Our patients have a very limited choice of hypoglycemic agents available once their creatinine starts rising up. Then the kidneys also should produce erythropoietins to maintain good hemoglobin levels, which is especially a problem, especially if the patient is suffering from various degrees of heart failure, be it preserved ejection fraction or reduced ejection fraction. Almost to the tune of 66 to 70% patients have that. And finally, yes, maintaining the calcium metabolic axis is also in the hand of kidneys. So these people are actually frail. They're highly prone to developing fractures. And yes, over a period of time, our patients do land up into stages where medicines become ineffective and the side effects of these medicines start creeping up, leaving the nephrologist helpless.
So now multiple things, so many things going on together. Initially, the student of internal medicine may feel a bit anxious or afraid. How do I put this all together? But the thing is, it's quite easy. The same way that you understand quantum physics, it's just, if you look at it, Dr. Ankita, Dr. Ashwini, it's such a tiny equation, E is equal to mc square. I mean, what more is there to it? If you just look at it that way, then suddenly this metabolic syndrome becomes very easy to understand and easy to handle. Energy is equal to mass, and C is the constant square. You explain this to your community, to your patients, and the vast majority will understand. Energy and mass have a link with each other, but it's not a linear link. It is not energy and mass are the same. So that's why when in pathophysiology of obesity, we say someone comes and says, I hardly eat anything, still I am gaining weight. Or somebody else comes and says, I have taken 500 grams of ghee every day and still I have not gained weight. We say there is a constant, there is a separate thing as well. So, but you can now explain that obesity, insulin resistance are driving all these things, and that C square may be different for different individuals. But let's move on to treatment. But talking of ghee, Dr. Ashwini, Dr. Balram Sharma from Jaipur wants you to complete this sentence, and he is joined by Dr. Amandeep Singh from AIIMS New Delhi. He's an assistant professor in medicine. So the statement begins like this: Dal bati churma, Rajasthan ka.
Yeah, so it is the dish of Rajasthan which is very famous all around, and obviously we all enjoy it. But there certainly we can't eat it every day. Otherwise, the dish will enjoy us rather than we enjoying the dish. So
They want
the
you
fact,
to complete the sentence. Dal bati churma, and what is the slogan?
I'm really not sure about it.
Maybe Dr. Lavdeep, Dr. Ankita will help out. So dal bati churma, Rajasthan ka surma. Now, is there an English translation for surma? So this is the battle cry of the Rajasthan cricket team or the Rajasthan athletics team, and also I think it's the battle cry of the Jaipur men's hostel. So, but surmas are kind of warriors. So, and they are smart kind of guys. If you eat dal bati churma, I mean that's fine, but then you have to exercise also. Then you have to go into high turnover kind of metabolic profile, a metabolic phenotype. Then things are fine. You can't just say that I will keep on eating dal bati churma every day, like Dr. Ashwini said, and not exercise. Dr. Ankita, now coming to dal bati churma, which is actually Rajasthan's favorite dish and mine too. What does this mean, Madam, dal bati churma, and how does it influence metabolic health? When we are speaking with people about diabetes care, about obesity care, what are the simple things you would like to convey regarding diet?
Yes, sir. So whenever my prescription begins, it begins with lifestyle modification. And if I spend 10 minutes telling about lifestyle, people often at end ask me, Madam, dawai to likha nahi hai aapne koi. You have not given me any medicine. I have paid to you for some medicine. So I think it is very important to understand that there's no cure, no drug can replace lifestyle modification. When we talk of lifestyle modification, we talk of diet and we talk of exercise. One has to see, body has a very simple balance along with the complicated, see, I agree, the metabolic rate, or what we call the BMR. Intake is equal to output. So if you keep intaking too much and there's no output, it is going to ultimately get stored in your body. So a simple brisk walk, 30 to 45 minutes per day, or what our American Diabetic Association says, 150 minutes per week or 75 minutes of high intensity per week is very, very important. In fact, it has been proven in studies that adding a 4 to 5 minutes or 5 to 6 minutes of brisk walk can give you extra 4 years of life. It has been published in ADA also. So starting with simple exercises is very important in the lifestyle. Then the diet has to be balanced. It has to be according to your cultural, I feel it has to be related to your culture, sir, because there are a lot of people who come up and say, I have done this diet, I've done keto diet, I have done intermittent fasting, and then they give up very easily on it. So it has to be a very sustainable diet, but you have to always maintain a state of calorie deficit. You have to always make it balanced, like simply adding some form of salad, some form of fibers before your carbohydrate slows the absorption. So some simple changes have to be made, but it should not be total avoidance of anything. It should be a balanced and a sustainable diet with the exercise. Then only our medical therapies also work better once the patient follows these advices.
Dr. Ashwini, would this be true for cardiology as well? Of course, we understand that a patient who has just gone through maybe an acute coronary syndrome would need stepwise cardiac rehabilitation. But otherwise, once that is done, or even during that part, what is the role of exercise and lifestyle modification in cardiac health?
So diet and exercise, these are the two pillars of good health. Rather, I will say that these provides us the primordial prevention, total cure. Otherwise, once you have suffered from the heart failure or say heart attack, then what we actually offer is palliative treatment. So, as you said, rightly said that energy and mass are well linked. It's ultimately the net gain per day by the body, which will transform into the mass in the form of obesity. Yes, rightly said that even if you are taking less amount of energy, but then your expenditure is far less than you are net depositing the energy in the form of mass, that's in the form of the adipose tissue, and that adipose tissue will is also brings simultaneously elevated levels of the cholesterol. These elevated level of cholesterol circulate into the blood. These are modified, deposited into the blood vessels, and then these forms the primary stage of blockage into the blood vessels in the form of plaque. Once the plaque advances and ruptures, then the acute coronary syndrome or heart attack is produced. And if they gradually progresses and occlude the blood vessels, then the chronic stable kind of angina, where you have the symptoms with heavy exertion or emotional stress, will be produced. So very well said that the diet, or in other words, energy, and then the exercise. If you are consuming same amount of energy, say X, but now you are physically inactive, then the position will start because expenditure is less. And at the same level of energy intake, same level of diet, if you start doing exercise, then obviously the burning of the calorie will start, and your weight, your obesity, your all the components of metabolic syndrome will curtail down, and this will give us the good health. So I absolutely agree with Dr. Ankita that for the prevention aspect, we should hit the metabolic syndrome at first, and in that category, the diet and exercise are far easy.
We are joined by Dr. Sneha Gadve. Madam is professor of medicine at Kolhapur in Maharashtra. And she says that, Dr. Ashni, many times we use this analogy with our patients. We tell them that our heart is a muscle. And that is true. Scientifically, that is correct. So the same way that you would take care of your other muscles, you exercise them, but you don't exercise them to the point of exhaustion or to the point of failure. Similarly, you have to exercise your heart. So you should go for aerobics, you should go for regular walks, but don't overdo it as well and don't underdo it either. So you follow the middle path and you gradually take a slow kind of a muscle building process. And I guess that is what cardiac rehab is also about. The kidneys also are muscles of a different sort, and they help in excreting all the poisons, all the waste products that we have. But many times we tend to neglect them. But Dr. Ankita, now we have been speaking of quantum physics and quantum medicine, and we said that it is a multifactorial kind of a thought process. Would that be true? We'll ask you and then Dr. Lavdeep. Would that be true for therapy as well? So, Dr. Lavdeep, do we have any hormones that we can use for nephroprotection?
Nephroprotection, as in per se using hormones, or the role of there are various agents which have been proposed to reduce or improve kidney functions. But then yes, we have anti-aldosterone. They have this one, these anti-inflammatory things, which is because the cause of CKD, as per the current guidelines, or as per the current literature, is baseline inflammation in the body. So using agents like finerenone, using agents which tend to reduce inflammation, might help us. Using prebiotics and probiotics to improve the gut microbiota might help in improving. As such, if you say that, if we have some studies which would say a particular hormone which might help in improving, so might be finerenone, which has shown some evidence in improving kidney functions over a prolonged period of time when used properly. That is one such agent which has been proposed. It reduces inflammation in the kidneys, it reduces inflammation in the body, and by reducing inflammation, it reduces proteinuria, which in the long run might help in improving the kidney functions.
The beauty of medicine actually is such that we always look at the person as a whole, and we tend to forget, and all of us passed our pharmacology long ago. I barely passed, to be honest, but that's a secret, so nobody knows how many marks I scored in pharmacology. So but when you look at all the drugs, you find that they are all endocrinotropic. Even when you are using an AR blocker, angiotensin receptor blocker, or an ACE inhibitor, that is acting upon the renin-angiotensin aldosterone system. If you're using finerenone, that acts upon the mineralocorticoid receptors. So these are all endocrinotropic drugs. When the nephrologist prescribes erythropoietin, then again, and be aware that there is something known as Goldilocks hormones. What Goldilocks hormones means is that if you give too much, then you get in trouble. If you give too little, then also you get in trouble. So for example, in chronic kidney disease, you would want the hemoglobin to be just right, not too much, not too little. Other hormones that are used in nephrology would be vitamin D. And then the astute nephrologist is aware of when to use native vitamin D and when to use activated vitamin D, because you don't want the PTH to be too high. Then you get renal osteodystrophy, but you also don't want it to be too low. Then you get adynamic bone disease. And there were drugs that were used in nephrology in the past. Aluminium, for example, that is when I was a student, they used to cause endocrine disease. So that mercifully is a thing of the past now. But Dr. Ankita, let's continue with this. We are talking of a cobweb of causation. We are talking of quantum physics. We've seen that the same drug can be classified as an endocrine drug by some, the same drug can be classified as a nephrotropic drug, or maybe as a cardioprotective drug. We'll come to Dr. Sharma shortly. So that is one way of looking at it. The same drug is being used in different ways for different purposes. But if we were to create the pillars of therapy, let's see if there is concordance between the pillars that Dr. Sharma uses for heart protection, the pillars that Dr. Dogra uses for nephroprotection, and the ones that we use for metabolic protection. So let's try to bring that E is equal to mc square equation into maybe 4 or 5 pillars for the audience. So let's begin with the drugs that we use for metabolic health.
Right, sir. For diabetes or glycemic control, sir, we have moved from a glycemic centric approach to a cardiometabolic renal approach now. We just don't want our sugars to be controlled. We want all our organs to be controlled. Similar is for the metabolic syndrome. We know it is not just affecting one, it is affecting all. And like, for example, you quoted about RAS and ACRBs, sir. So we know that RAS activation is one of the important pathophysiology in metabolic syndrome. Then another is tubuloglomerular feedback. Now, if we look at the management, the first line of drugs that we are blessed with some wonderful drugs now, which can help us as an endocrinologist, as a cardiologist, as a nephrologist. First, I would like to start with the SGLT2 inhibitors. It was a revolutionary in 2013 when the first it was a cardiac drug or probably an endocrine drug which came into the American Cardiology Association paper. So we have the SGLT2 inhibitors, we have the GLP-1 agonists now, which are revolutionary for metabolic syndrome. Now, I think it is a fight. We see one SGLT2 inhibitor put by an endocrinologist, one SGLT2 inhibitor put by a cardiologist, and another one put by a nephrologist. So it is all a collective because we are fighting some common pathophysiologies like insulin resistance, like hyperfiltration, probably inflammation, probably endothelial dysfunction. So the first line of drugs that come into our management were metformin. Initially, we just had metformin. But now we've moved to more better drugs with a better cardio, renal, hepatic or metabolic protection, sir.
Dr. Ashwini, your take on this. So SGLT2 inhibitors, can we classify an SGLT2 inhibitor like dapagliflozin as a quantum drug, as a quantum intervention?
Yeah, definitely, sir. So previously, when I was doing medicine, we used to say that the patient is having diabetes, he is having micro and macrovascular complication. Our aim was to achieve the euglycemia, and then if there is any complication, then take care of that. But now we have evolved that no, it's not so. We want to control glucose, and simultaneously we want that there should not be any micro and macrovascular complication. So your kidney health comes into the microvascular complication, and heart health, that means the heart attack kind of thing, comes into the macrovascular complication. Now we know that we should choose the best weapon which can take care of all or as much as possible. So with dapagliflozin, it came as a drug for glycemic control. That means a drug for diabetes mellitus. But soon we came to know that it is safe from the cardiac angle. When we more and more evaluated it, we came to know that yes, it decreases the 3-point MACE. That means it decreases the cardiovascular mortality and mortality from the incidence of heart attack and the incidence of stroke in combination or differently. Then also we came to know that it is a wonderful drug for heart failure. Rather, in the field of heart failure, we investigated and we have reached to the level where irrespective of diabetes, irrespective of the kind of heart failure, whether heart failure with the reduced ejection fraction or mid-range ejection fraction or preserved ejection fraction, it is effective. And it is I will say that it is the drug, one group of the drug which is most effective in patients with heart failure with preserved ejection fraction. So out of the available and anti-diabetic medications, if we have to choose one, then we will not choose on the basis of HbA1c levels or fasting and postprandial glucose, but we will also see that what are the end organs affected or at risk from this level of diabetes, and accordingly we will choose one or more medications or one another or in combination. So very well said that yes, we are moving away from the linear medicine kind of philosophy to the quantum medicine.
Thank you. Dr. Lavdeep, many times in renal patients, we feel afraid of using drugs. One, we are afraid that the drug may cause renal toxicity. That would be the worst. Second, we are afraid that it may not cause any harm, perhaps, but it's not going to cause benefit also, and it might cause drug-drug interactions. And third, that we are afraid because of reduced renal clearance, it won't work at all. So these are some worries that we have. What about dapagliflozin, and what changes have taken place in the nephrology pharmacotherapeutic landscape? How confidently can we use this drug in people with a lower EGFR?
Dapagliflozin as a molecule has evolved over the last decade. If you see 2016, wherein we had limited molecules like canagliflozin and empagliflozin, which were used in GFRs not lower than 45. So we have come a long way. Then from 45 we went down to GFR of 30. This was in 2019 and 20 when we said we can use it up to GFRs of 30. That was the time when dapagliflozin was also used in patients without diabetes also for the first time, where the study of DAPA-CKD had come, and that was a path-breaking study because when dapagliflozin was used in the absence of diabetes also, it was shown to be fruitful. So dapagliflozin is a good drug. Then onwards we came last 5 years, we have gone down to a GFR of say 15. Then finally now the recommendations at this time suggest that dapagliflozins can be initiated at GFRs even in advanced kidney failure patients and can be continued up till the initiation of hemodialysis. So until the initiation of hemodialysis means that yes, dapagliflozins have shown their strength to be a safe molecule as well as an effective molecule at the same time. Because most of the patients suffering from end-stage renal disease, as you said, sir said rightly, is that they don't have kidney disease. They have multi-morbid conditions. They have multiple conditions which add to the overall morbidity and mortality. And as I usually say to all my patients, a patient of dialysis never dies on dialysis or never dies of kidney disease. That's a rare happening. They usually have many more reasons to die. It can be a brain hemorrhage, which we do not know where it comes from. It can be a cardiac issue, which usually happens to all of them. Be it anything, the end result is the same. But then using these agents might actually help us in reducing not just hospitalizations for heart failure, but if used early in delaying dialysis, reducing proteinuria. But as you said, as a good physician, it is our duty to be a little more with the patient when they are using such agents, to tell them or to convey them that yes, when you are using this agent, you drink a little more water, you void more frequently, and at least maintain a good genital hygiene, because not all patients, as if I say more water, the next question comes, what happens with patients with kidney disease who do not have urine output, or patients with a severely reduced ejection fraction? So we tell them yes, that we have to be very careful about UTIs. We always mention in our prescriptions to maintain a good genital hygiene. We also mention them to get a urine routine for every febrile illness. And as the algorithm goes, that we stop SGLT2 inhibitors, ACE inhibitors, and metformin on sick days. These are not the medicines to be given to patients who are not keeping well or are admitted in the ICU with any disease, say sepsis or anything, because they will worsen kidney functions. So, as I said, that being a nephrologist is equivalent to being a kidney physician, wherein more of the medicine part is to be covered than this one.
Point well taken. If your patient is stable, the patient has stable diabetes, stable cardiovascular disease, stable renal disease, you can use the drug very safely. If, however, your patient is so unstable that he or she is not able to eat properly, he or she is not able to drink properly, so there is gastrointestinal impairment, or your patient is hemodynamically unstable, you are struggling with inodrops in the IC or in the dialysis unit, then the last thing you would want to prescribe is DAPA. But in general, in the vast majority of OPD patients, you can use it. Dr. Ankita, madam, one specific question. You have worked in government setups and you have also worked in private setups in different states. How challenging is it for a healthcare professional, especially maybe for someone from the male gender, to take a history of pruritus vulvae? How do we differentiate between urinary tract and genital tract infections? Would you like to share some suggestions with us? How can we take an empathic and sensitive history of genital tract infection in both men and women? And then how do we manage it further?
Absolutely, sir. This is almost at least 2 or 3 cases in OPD are experienced when they've developed severe vaginitis. They've landed up with the gynecologist. They've landed up with 10 different doctors, and SGLT2 inhibitors are still continued. So either only urine RMs are done, people are not asked about the histories, and yes, females are very conscious in sharing about this. Until you poke them, you ask them again and again. I think once when the drug is initiated, educating them is very, very important, because prevention, they are not aware that this can cause this side effects. Teaching them, telling them at the beginning can help us solve a lot of questions. We have to differentiate between UTI and the GUT infections, where they keep complaining of the itching is there. Even they develop some form of females end up developing ulcers. Even the males end up having phimosis, and it is not identified that it is because of the drug. So I think knowing contraindications or knowing side effects of the drug is very important than just knowing the indications of the drug. And right education is important. Asking patient on each follow-up about the side effect of the drug is important, sir, because simply just withdrawing the drug can be an effective treatment, rather than patient even getting treated as herpes, taking 10 pills a day, taking all intravaginal pills, applying 3 ointments, whereas only simple withdrawing of the drug and increasing the hydration, as I mentioned, can be helpful.
Thank you, ma'am, for raising this point and for sharing it so candidly. So let me reinforce what Dr. Aneja madam has said. First of all, ask, take a history. So that's ask. That all of us can do. But if you're going to ask in a judgmental manner, let us say there is a young gentleman in front of you and your tone is such, and you don't believe in pogonotomy, and then your tone is such that you are being judgmental. The person in front of you, see, he is viewing you as a superior figure. He may feel afraid, he may not share his history. If you are going to give a tone that any kind of a genital tract infection is sexually transmitted, people are not going to share the history with you. So you speak in a non-judgmental manner. Also, while asking, it would be a good idea, especially if you are younger and if you are from the opposite gender, to begin with non-threatening questions. Non-threatening questions would be, how are you? Anything I can help you with? Any fever? Any infection anywhere in the body? Any boils? Any carbuncles, furuncles? This is all non-threatening. Any cough and cold? Okay. Any lower GI symptoms? Any problem with micturition? Slightly threatening. And then any infection in the genital tract. Now, what does infection mean? You have to specify the symptoms. Do you have itching? Do you have pain? Do you have abnormal discharge? Abnormal discharge should come in at the end if you are from a different age group, from the opposite gender, and if you are from a different ethnic group. So all these things have an impact on how the patient relates to you. Also, the duration of your relationship with the patient. If it is just 3 minutes old relationship, then you are not going to ask immediately about exposure to STD. So from non-threatening to threatening. Now you've reached the lower abdomen when it comes to questioning. So if there are vague symptoms, then your tone will change. I understand it is possible. So madam, why I'm asking is because some of our medicines can cause side effects. Again, don't jump to that genital tract infection side effect. Then your tone will be, actually, you see, some of our drugs, they increase glucose, they reduce glucose, they can cause edema. So that's why I was asking. And then suddenly the patient comes with, yes, I did have edema 6 months ago when my previous doctor gave me the medicine. And then that doctor told me to take this medicine. After that, I've got this. So now you know how to handle. The patient has told you. After asking, E is for evaluate and inspect. We understand that many times we are not able to do that in our OPDs. But if you are not able to do, please refer to the right person. And if the treatment is local estrogen, let it be so. If the treatment is anti-trichomonal treatment or local or therapeutic or systemic, let it be so. But if the treatment is going to be discontinuation of SGLT2 inhibitor for a short period of time, that must be managed, like Madam has said. Dr. Ashwini, apart from dapagliflozin, we have sitagliptin as well. And sitagliptin-DAPA combinations are used frequently in the OPD. What is the status of gliptin use, especially sitagliptin use in cardiac practice?
So I will say that DPP-4 inhibitors use is now increasing. primarily these were used for the glycemic control purpose. And see, we simultaneously we wish and that our cardiovascular health should not be compromised. So we have the TICO style with the sitagliptin, and we know that it is fully safe from the cardiovascular perspective. It won't increase the risk of atherosclerotic disorders, it won't increase the risk of heart failure, and it is safe in these patients. Whatsoever is there. So definitely the use is increasing, and we also know that just like metformin, it's a very brutal medicine. So and that's all our purpose in these disorders. When we see that around one fourth of our patients are suffering from the metabolic syndrome, in those conditions, we need a medicine which is a weight user, where the significant dose modification is not required, and then it does not compromise the health from the cardio in the form of atherosclerotic disorders or heart failure. So, considering all these parameters, the use of sitagliptin is definitely now rising in the patients of cardiovascular disorders who are having the diabetes. As we said right now that SGLT2 inhibitors are offering us advantages in both heart failure therapies as well as in the atherosclerotic disorders. We are frequently combining it. With that, we will have the better efficacy for the glucose control. We will have the better protection of our target organs, and we will have the therapeutic target achievement with these combinations.
And one added advantage, Dr. Ashwini, would be the lack of hypoglycemia. So as it is, the cardiologists, the nephrologists, they struggle with so many complaints, so many challenges, acute, subacute, chronic. And if you were to add hypoglycemia, iatrogenic hypoglycemia to that long list of challenges, then practice would become very tough. So that's an added advantage. It's nearly more than 50 minutes actually since we began talking, but the best part of being with friends is you don't realize how time flies. Dr. Ankita, if you allow, one last question we'll take, and this is from Dr. Bidita Khandelwal. Madam is Professor of Medicine in Sikkim. So she says, all of you have so beautifully put together that common tapestry of metabolic syndrome, heart disease, kidney disease, metabolic health. Not only have you shared a problem statement, you've also shared a solution statement. The same drugs, once upon a time, they may have been considered endocrinotropic or glucocentric drugs. The same drugs like SGLT2 inhibitors, DPP4 inhibitors, other drugs that form the pillars of heart failure therapy or CKD therapy, they are being used for multiple purposes. But a clinical question she shares, and the question is, somebody comes with ghabrahat, sense of uneasiness, sense of discomfort. There can be 1,000,001 differentials. So somebody has come with ghabrahat. Let's take the entire question together, and we hope Dr. Lapeep comes in. Now that ghabrahat can be a hot flash. It can be hypoglycemia. It can be acute panic attack. Dr. Ashwini, it can be an unstable angina. It can be an anginal equivalent. And it might be hypokalemia or hyponatremia. So many things together. We'll begin with Dr. Ankita and then move on to Dr. Ashwini. In your practice, how would you handle ghabrahat? Any mistakes that you've made in the past, and where you're hyper vigilant now that you don't miss these reasons? And how can drugs like DAPA and sitagliptin help you offer safe treatment to your patients, safer treatment?
Yes, sir. So I think as an endocrinologist, the first thing that comes to my mind is hypoglycemia. I make sure I immediately, if I have access to the blood glucose, it is checked. If I don't have access, I do not wait to document it, but I offer some carbohydrate-rich snack to the patient. Then the other is I make sure, because every examination begins with the vital examination. Second thing, I make sure it's not a hypertensive emergency, because as an endocrinologist, I am not just going to check the sugars, but I'm going to make sure to check the blood pressures also. Then rarely, sir, now because we are so much into endocrinology also, only I have rarely had patients who've been here and there for ghabrahat and have ended up with the diagnosis of pheochromocytomas or paragangliomas. That is somewhere one diagnosis which was missed sometime by me. Now that I make sure but that is a very very rare cause. So looking at the common examples, probably talking to the patient, extracting some history of some acute event, looking at the vitals, looking at the blood glucose is primarily what I do in my OPD practice. So, or probably if document a ECG also sometimes may be very very important.
And Dr. Ashwini, your take, the same question, and let's add also from the ECG, apart from all the ischemic changes that you see, can we find out about dyselectrolytemia? Do hypokalemia, hypocalcemia, hypomagnesemia, do they all look the same on ECG?
No, all doesn't look same in ECG, but you are very in a very sensitive manner. You are directing us to one by one organs which can manifest with the gabrat. And honestly speaking, it looks like very trivial complaint, but the n number of differential diagnoses are there. And until unless we catch it and we resolve it, the patient will not come out of the gabrat, and he will rather transmit the same gabrat to us also until unless we come to a diagnosis. Yes, so as you said, rightly said, that unstable angina might be the one on conditions where he may have uneasiness, or it may be just an angina equivalent. Apart from that, if he has, say, atrial fibrillation or atrial flutter, yes, he may come to us with gabrat. Sometimes atrial flutter, in atrial fibrillation, most of the time we can see, we can appreciate it by looking at, by feeling at the pulse. But in atrial flutter with fixed block, many times we feel that it is simple sinus tachycardia of say 100, and we may miss it until unless we will get the ECG. Then, if you have hypokalemia or hypomagnesemia or hypocalcemia, you may have VPCs or APCs. Those again give you a feeling, a sinking feeling, kind of sensation, and until unless we will take care of it, the patient will not come out of those sensations. Yes, we can differentiate that from the hypokalemia and hypocalcemia. If you have the checking OST segment, then depression of the ST segment, widening of the QRS, this checking of ST depression, decreased height of the T wave, then it may be hypokalemia. In hypocalcemia, you will see the prolongation of the QT interval. The same is true for hypomagnesemia also. So at least the patients on therapy, various therapies for heart failure or atherosclerotic cardiovascular disorders, we will always see that once if he is complaining of uneasiness, I will always ask him the history, when it set in, what there was any change. Meanwhile, I will also pursue with these vital examinations. And if I have not found anything, then definitely my next line will be to go for an ECG first.
Thanks. And now you're putting things in perspective for us. And then we also realize now we are so lucky with the newer drugs that we have. With the older drugs, for example, digoxin, there was so much of checking, cross-checking that you had to do. But now with the newer drugs, let's take dapagliflozin, you actually don't worry about electrolyte dysfunction. Even when you use dapagliflozin with a drug like finerenone, Dr. Dogra mentioned that adding dapagliflozin actually reduces the risk of electrolyte dysfunction or hyperkalemia. So it makes things much easier. And thanks for putting all this in perspective. Now I will look at my next patient's ECG with more care, with extra care. But Dr. Dogra, we were discussing about ghabrahat, uneasiness, discomfort. So what are the common causes of ghabrahat in the nephrology OPD? And how do you manage them? Apart from the cardio-oriented and the endocrine-oriented comments that we have got.
Obviously, sir, ghabrahat is one of the most common symptoms, I believe, which presents to us in the OPD. Very recently, it might be as early as today morning, we had a lady almost in her 60s, not old also, I won't say that, maybe around 55, 60, and
Dr.
she was not...
You called us young. That is the best thing in the world that has happened to me today. So,
that's what we learn to be careful with time. That's what. So this lady presented to me with, she was just uncomfortable. घबराहट हो रही है, और very commonly जैसे हमने रात को नींबू पानी पिया था पर घबराहट हो रही है. So exactly as what sir has also said and Dr. Ankita also pointed out, that we tend to overreact and overact when it comes to घबराहट, because it is just an umbrella sign. Gas बनी थी. Gas is an umbrella sign. We should not miss an MI sitting inside or something even worse, which can be anything. Not just to name it. When it comes to the nephro perspective, and not talking about the cardiology part of it, though this lady, when I examined, she had herpes in that area. So shingles was the presentation. And it was just she was just having some pain over the left hypochondrium, and then she had lesions which were erupted, and she was unaware of them. She was unaware of them. There were a couple of lesions in the same dermatome. So this happened today morning. So, but then this is not just one. This is just one part of it. Even more common, especially in patients with diabetic kidney disease, diabetic gastroparesis is very common. Just to involve a delayed emptying of this one. Also, patients with uremia experience gastroparesis as well as nausea, vomiting, secondary to the uremic milieu which develops in the body. Not limiting ourselves to kidney and thinking in a wide array and ruling out essential causes which need immediate intervention, be it cardiac, be it an LRTI which will worsen the cardiac status, or be it rising creatinine which can be a sign of the worsening of AKI should is important, and that should be looked into. Just prescribing something for ghabrahat, which is actually very important once if you are conversing or having a telephonic conversation on the phone. So I do mention, and as I've learned from my teachers also, to mention that whenever they call you and ask you up for this ghabrahat, we tell them, "Aap ek goli le lo," but then revert to us in case you do not improve in an hour or so. So this is something we should not ignore.
Thanks, and thanks to all of you. We've learned so much today. What I have learned, and I speak on behalf of all our colleagues from across India, what we have learned is that internal medicine is such a beautiful subject, so interconnected. All the organs talking to each other, listening to each other, all the hormones and the autonomic nervous signals, the neurotransmitters talking to each other, listening to each other. If you talk and listen to each other the same way that we have listened to all our colleagues today, Dr. Ankita, Dr. Ashwini, and Dr. Lavdeep, if we talk and we listen properly, then we remain in harmony, we remain in good health. But there are times, like in the metabolic syndrome, where one or two organs decide to, sort of get in an angry mood. Maybe the beta cell or maybe the insulin receptors. And then once they get angry, the insulin receptors decide to act a bit pricey. Then one by one, all that connection, all that communication begins to unravel. But the good thing is that if you talk to your patients about diet and exercise, and then if you use the right drugs to calm down those angry insulin receptors, to calm down the SGLT2 protein, maybe to calm down the incretins, then you can reverse that trajectory towards ill health, and you can come back towards better health. But for all that, you need to take a history. You need to listen to the patient, and we need to listen to each other. But together we are strengthened. And this proverb from Haryana, and Haryanvi and Rajasthani have a lot in common. To people from outside our states, what we are told is that most Rajasthani speakers, Marwadi speakers, can understand Haryanvi, but the opposite is not true. So I, for example, would not be able to understand Marwadi. But Dr. Ankita, before we conclude, a message for everyone who is logged in. Our topic for today is metabolic syndrome, crosstalk between the various organs.
So I think for every disease, it has to be an integrative approach. And for metabolic syndrome, lifestyle has to be the cornerstone in the management. So keep walking, stay happy, have a healthy diet. And we are blessed with the yoga, which is Indian form of exercise. We should all be moving, because they say sitting is the new heart attack. So keep moving, stay hydrated, eat well, stay stress-free, limit your screen time is the message I would want to give. Thank you, sir.
Thank you. Dr. Ashwini, there's a comment from Ajmer Medical College. They say that you left your heart there in the girls' hostel 20 years ago.
I'm really not aware, but I feel that my heart is in me.
Okay. So any comments on how to keep your heart with you and how to keep it healthy?
Yeah, so not much has been very well said. I will also add here that we should not wait for a disease to creep in. Rather, we should just pick up the risk factors which are creeping all around us. We should very well take care of our healthy food habits. We should have a good exercise program for us. We should have a proper sound sleep. We should decrease the stress to the tune that it is now positive stress or eustress for us, and should never go towards the distress kind of side. And then obviously we should take care of our environment as well, because now the pollution is a factor which is not very well measured, not very well appreciated, but then it is definitely a risk factor for our metabolic syndrome. And rather than testing the blood sugars or cholesterol first, I would say that sit down and just think that what are these risk factors in me and in my family, which I will take care first, and then I will go for assessment. Then, if my glucose is high, yes, I need to take only medicines because everything else I have already taken care.
Preventive
Thank you,
checkup
Doctor.
have to be the focus, sir. What we are missing, probably we only deal when the disease has already developed or the complications has developed. So teaching the patients or teaching the community the importance of preventive healthcare is also very important.
Very well said. And what Dr. Sharma and Dr. Aneja have added is that it's not just about the organs talking to each other, it's about the environment talking to us and us talking to the environment as well. So, environmental medicine is another concept that is coming up rapidly. Dr. Dogra, when it comes to metabolism, then usually it's the kidneys and the bladder which have the last word. So, the last word for you today.
It's happy to see that the awareness, as Sarah said, and we realized that over the last couple of decades, awareness regarding kidney diseases has improved a lot. This will obviously help in improving long-term outcomes. And then, yes, if we tend to manage kidney diseases in early phase of time, we will have more time for maintaining a good pogonotomy, as Sarah has told.
But we need the meaning. And then Ravya and Raghav Sharma, they have a specific question as well. They say, is there any randomized control trial which says that pogonotomy reduces quality of life?
But at least I don't know from the if it is done for the patients or for the doctors.
But we don't know the meaning of pogonotomy yet. I mean, Ravya Sharma knows and Raghav Sharma knows, but the rest of us don't know. So, what does the word mean?
I think I would not be the right person explaining it, sir. It's easy. It's something we can Google. It's something we can Google it, but I don't think I would be the right person doing it. The art of what I don't do actually.
But so pogonotomy means the art of cutting a beard. So that we will leave for a separate discussion. Yes, and thank you for us for pointing that out. So that we will leave for a separate discussion when we visit the pink city of India, Jaipur. But till then, it's been great. Dr. Ankita, thank you so much. Dr. Ashini, thank you. And Dr. Lavdeep, thank you for tolerating that good-hearted, light-hearted teasing. It's been great.
Thank you, sir. Thank you.
To everyone who is with us, this is season 3.0 of 4D going on. And like we said, diabetes is a dynamic disease. Diabetes management is even more dynamic. And we need to keep on having this detailed discussion and dialogue amongst ourselves. We learn so much from each other. We feel rejuvenated. We feel more enthused. So when we go back to the OPD tomorrow, when we go back to the dialysis unit or the ICU or the endocrine ward, let's go back in a rejuvenated, more re-energized manner. And let's do the best possible for our fellow citizens, those citizens who trust us with their very lives. Thank you and Jai Hind.
Thank you, sir.
Thank you, sir.
Thank you, sir.